Bismillah ar-Rahman ar-Rahim. On behalf of the board of the Middle East Venous Forum, I would like to welcome all participants. We have about 103 participants so far for the first online webinar through the Middle East Venous Forum. This webinar is one of the education arms of the forum, which we are hoping to continue on a monthly basis with international and national speakers. It will include lectures, difficult cases, imaging, and all other options of education in the field of venous disease. It will have CMEs with it. Unfortunately for this one, we don't have the CME yet, but we can ask for it through other organizations. However, there will be CMEs in the future. Just before we proceed with the speakers, I like to introduce the board members of the Middle East Venous Forum. And they are from different countries. Ma'moon Bashir from Jordan, Samir Kusayer from Saudi Arabia, Francisco Cirino from United Arab Emirates, Karen Bauer from the United States, Nikos Lapropoulos from the United States, and Martin from Bahrain, Martin Marish from Bahrain. So these are the 7 members of the board of the Middle East Venous Forum. There will be questions during this session, so anybody who has a question, you can do the question and answer. Also, you will be all muted during this session, except for the speaker. This is controlled by Khalid, who we have to thank for this also webinar. He is from Prime Conferences that we did the first meeting with them in the United Arab Emirates. Our renowned speakers for today are very well known to you all. Nikos Lapropoulos, if you don't know him, you need to skip out of here because he is one of the known people in venous and vascular imaging in general. He's professor in Stony Brook. I think I'm right about that. He has a lot of publications. Dr. Patricia Thorpe, and I will introduce her with her lecture. And Martin Marish from Bahrain, I will introduce him also with his lecture. The order of the lectures will be imaging, then Dr. Thorpe will talk about factors successful for venous reconstruction and interventions, and then Martin will talk about venous stenting in young patients. So far, we have 131 participants. We know we have about 420 registrants, so the number will increase as we go. So with that introduction, we will see you again hopefully next month. And our first speaker will be Nikos Lapropoulos, who is, as I said, known in the area of imaging and vascular surgery, and also very well known in education. Above all, he's a friend of mine. Nikos will talk about the imaging in venous disease. Nikos, it's your area.
Thank you, Munir. Can you see my screen?
Yes, sir.
Well, hello everybody, dear friends, colleagues, best wishes from New York. I'm gonna set up the floor for Patricia and Martin for their talks. When we talk about venous obstruction, this could be intraluminal, extraluminal, or both. It can be, of course, acute, chronic, on both. In such an area, the venous outflow resistance may be increased, leading to the signs and symptoms of chronic venous disease. Chronic iliofemoral obstruction has major impact because there is higher incidence of post-thrombotic syndrome. It is the only condition where we see venous claudication, and of course increases the chances for recurrent DVT. It is important because failure of recanalization is more common in iliofemoral veins, like you see on this example here. Now, unlike the May-Thurner syndrome, which is a very big misnomer, area of extrinsic vein compression may occur on the left from the right, on the right from the right common iliac, and left from the left, but also from external iliac veins and the internal, and also rarely the guineal ligament. However, combinations of the obstructions occur, and this can be in addition or separate to deep vein thrombosis. These are publications which is in press in the European Journal of Vascular Surgery that demonstrates that 16 references quoting Virchow for putting the iliofemoral compression in DVT on the left side, but this is not true. We sent a paper for official translation in Germany, and in this paper, there is no word for iliac vein or thrombosis. So this is a big mistake and erroneous. And clearly, it is not MEVF, but Dr. McMurridge, who in 1906 described the first in the British Medical Journal, the iliac vein compression. And in fact, there are 1, 2, 3, 4 people before MEVF who described it. The term syndrome appeared first time by Cochrane and Thomas in 1965. And of course, the multiple publications after that. Now, when we look for diagnosis of iliac vein obstruction and using ultrasound, we have direct criteria as the planimetric diameter stenosis, like we do with a venogram or the IRUS, the velocity ratio, luminal changes such as well thickening and webs, and the indirect criteria such as non-phasic flow in the proximal common femoral vein, asymmetrical flow pattern in the common femoral, non-phasic flow during Valsalva maneuver, low or no velocity augmentation in the common femoral, presence of collaterals, reverse flow in the ipsilateral iliac vein, cephalad flow in the inferior epigastric vein, reverse flow in the deep external pudendal vein, and difficulty into compressing the common femoral vein. Ultrasound is the most operator-dependent technique, and rigorous training and experience are necessary. Here, we see several patterns of flow in the common femoral. On the top left slide, we see a normal phasic flow in the common femoral, a normal response to Valsalva in the middle, and a normal response to distal augmentation. On the bottom left, you see that a vein collateral with non-phasic flow, and then you see another patient with a collateral with partial phasicity, and on the other side, you see the collaterals of the iliac system. Non-phasic flow is diagnostic for obstruction proximal to imaging site. However, a normal waveform cannot exclude proximal obstruction. Now, during imaging, it's very important to evaluate the inflow. That is, the common femoral vein, the deep femoral vein, and the femoral vein. The femoral or the deep femoral, most common, it has to be patent in order to perform stenting. For example, here is a patient that done from a colleague of ours with stent occlusion because the patient had poor inflow. See, this is the contralateral side, the beautiful flow and augmentation, but the ipsilateral femoral vein, common femoral vein, has a lot of synechia and very little flow. So if you put a stent in a patient like that, the stent obviously is going to occlude. So when you do your diagnosis, it's very important to establish good inflow. Now, here are the normal iliac veins, and in about 2/3 of the people, some degree of compression exists by the artery over the vein. This actually is an innocent bystander. People like that should not be treated because this produces no hemodynamic, compression. And here you see, play the video, you see reverse flow component. The iliac vein has the same flow like the artery. With a curvilinear probe, the iliac vein is red flow, but it's blue, like the artery. this indicates ipsilateral obstruction on the common iliac vein. And you see that in here, on the Doppler, the flow in the artery and the vein in the same direction. And here you see why is that. This is a very tight stenosis of the ipsilateral common iliac vein. And what you see here on the video, you see the right common iliac, look how much bigger it is from the artery, because a compensatory dilatation and high flow, because the right side drains the left and the right lower extremity. And of course, we have different types of obstructions. Here you see a typical one where the right common iliac artery is compressing the left common iliac vein over the 5th lumbar vertebra. If the ratio is more than 2.5, that's indicative of stenosis, but sometimes the absence of the ratio, it cannot exclude the possibility of stenosis. For example, people having an occlusion or very long, very tight stenosis. In some people where the aortic bifurcation is somewhat lower, then both arteries compressing the iliac vein. In fact, when this phenomenon occurs, the compression leads to an occlusion and is much longer. But even in those cases, it's very easy to pass a glide wire and treat the lesions, as my colleagues are going to tell you later. Now, because seeing is believing, it's a beautiful paper on cadavers demonstrating that this is not thrombotic, but this is collagen, and it is usually called as type 1, that connects the adventitia of the posterior wall with the adventitia of the anterior wall, and often makes this synechia and these channels like you see here. And if you see, using a special staining for collagen, almost the entire thing from the adventitia to adventitia stains as collagen. And this will make sense because when you see the criteria for the different lesions developed by McNuritz in here in 1906, is exactly what we see with venography and IBUS nowadays. So you have a single channel with thickening or multiple channels, you see on these different models. And they are depicted in a recent publication, which is in press in the European Journal of Vascular Surgery. And sometimes you will see a venogram like this. All these things you see here is exactly the same vein. These are not collaterals. These are the synechia that make multiple lumens. In a case like that, you need to go to any of them and connect the iliac with the IVC in order to deploy your stent. Obviously, you should not go to a collateral like in here because you're going to the wrong path. And here is a non-thrombotic compression by the right common iliac artery, which is a very high velocity, which is bigger than the artery. The prevalence of symptomatic non-thrombotic iliac vein compression is actually unknown. And here, this is what usually happens. This is one of our patients that had the compression for a long time, but never developed symptoms. But he underwent spine surgery, and during spine surgery, he developed iliofemoral thrombosis. And you can see the vein is compressed and is thrombosed. So what happened is, this stenosis that was an innocent bystander with a thrombosis became very important. When we thrombolize the patient, we reveal the stenosis, and then of course we put the stent. And here is a scenario of chronic obstruction. You see now, the iliac vein is much smaller than the adjacent artery. Even the supine position, the iliac vein, so the same diameter of being larger than the artery. If the vein is smaller than the artery, then something is wrong, and always wrong. So in this patient, the diameter of 7 millimeters is because of chronic obstruction and contraction of the vein. You see beautifully the large collaterals with a non-phasic flow. Now, when you have deep vein disease, right, like in the patient I showed you earlier, you may, because of thrombosis, do thrombolysis, but then you may have erythrombosis. Then you're going to hear from my colleagues later, having stenting, that you may get restenosis, erythrombosis, stent fracture, or migration or malposition. The way we image these people are with primarily with duplex ultrasound, MR, CT, and usually do phlebography and IVUS with intention to treat. And here you see one of our patients at follow-up is a male, 26 years old, with left iliac vein stent thrombosis. You see very nicely here The ipsilateral side, the left side, has very poor augmentation of the common and no-phasic flow, where the contralateral side has beautiful augmentation. And as you see here, the stent is clearly occluded. Why this patient is occluded? Because the patient has antithropin 3 deficiency. And one common reason for people having occlusion is either some really bad hypercoagulability, or most commonly, lack of compliance with anticoagulation. And of course, technical issues that we're going to see in a little bit. Now, here is an asymmetry on the inferior epigastric veins. You see here, on the right side, where is a normal, the epigastric vein is the diameter of small, it's like 2.4. On the other side, where the left iliac vein is occluded, the epigastric vein is 6.4 millimeters. And also, you see the flow here? The flow is going up to the heart, when the epigastric vein should be above the line, going to the groin, because the epigastric vein drains into the great saphenous vein at the groin. So when the flow is inverted, you know there is obstruction, right? So a reversal of flow on the epigastric vein indicates ipsilateral iliofemoral vein obstruction. And here we see a patient with a stent fracture. You see here on the ultrasound, looks a bit weird, but it's funny because you lose the continuity of the stent right in here, right? This indicates that the stent is being fractured. However, to see this better, you see the CAT scan, you see very nicely here the fracture of the stent. And you see the magnification, how the stent has been fractured. Now, in a study that's not been published yet, but with the University of Rigshospitalet in Denmark, with Dr. Niels Bakker, we did a 10-year follow-up using CAT scan. And we found a small number of stents fracture, but unlike the arterial stents, stent fracture is actually most of the time a benign phenomenon. And here you see a beautiful demonstration from our study in Denmark with a stent fracture, right, over the fifth lumbar vertebra. And here you see a stent with luminal reduction, but because of poor dilatation. If you do your venogram at the end, right, sometimes you see more or less a good lumen, but you won't have a good idea unless you do an IVUS to see if the stent is really well opposed. And here basically there's a significant technical error with bad malopposition and poor dilatation of the stent. And you can see very nicely here on the zoom view, look how small is the stent and it's thrombosed obviously. Then you have, on our follow-up, we do the diagnosis for problems. This is a wall stent under the right common iliac artery in the lumbar vertebra, and it has a diameter of 9 millimeters. Originally, this stent was 14 millimeters here. What is interesting, when the stent goes inside the vena cava, right, it goes down to 7 millimeters. This is because at the end, at the proximal end, the wall stent has not good radial force, and when it's bathed by blood into the vena cava, it fails to open and have a reduced diameter. That's a property of the stent. And you see the diameter further down, the stent was 14 millimeters, now it's 13. So that's a very good diameter to have, you know, a year later. Here is a patient. I know many people taught in the past, and I know Patricia taught us, do not go big or go home. You use like better stent diameters. In the era where there's the wall stent and Dr. Razou preached to the crowds, use as much as you can, big stent. That's not always a good case, because as you see here, if you overstent the vein, you cause tapering and stenosis distally, like you see on this patient. And now with the nitinol stents, we know not to do this anymore. And I'm sure my colleagues are going to talk to you after me. And here is a place where we call difficult angle and poor apposition. It's inappropriate to finish your stent right at the origin of the entire iliac vein, because the iliac vein diameter and the angle is big and always has flow and thrombus developing under the stent. So you see, if you have experience, you can discover all these things with regular ultrasound. As I said though, ultrasound is very operator-dependent technique, and rigorous training and experience really necessary. And here is what you see. When you go to the vena cava, one of my colleagues in Brazil, early his experience, he put 2 big stents in the vena cava. What's the problem now here? He overdilated the vena cava and stretched the vena cava above, causing stenosis. look at the stents, the aorta here, and look at the tight stenosis of the vena cava because the stents are too big for the cava, basically. And another phenomenon we see is the thrombus layering that can happen acutely. So you have a first thrombus, or what we have this fibrin sleeve that develops over time and described very well by Dr. Williams, who took biopsies from inside the stents and demonstrated that this actually fibrin and collagen is not actually thrombus. And you see here on the zoom magnification, you see this, the venogram may appear good, but you see this filling defect because the patient has thrombus, or if you like, fibrin layering. Now, there are several papers, but very few new ones, that they look at the stent geometry after venous decanalization using ultrasound. And basically, this paper in Phlebology 2019, it showed that the ultrasound in good hands has sufficient accuracy in detection of stent changes and its patency. Now, what are the key points here? First, for the iliac vein compression. Iliac vein obstruction is fairly common and most often asymptomatic. So please don't treat left, right, and center people with iliac vein stenosis unless you have symptoms appropriate to the stenosis. It is not congenital in the vast majority of people and develops over time, starting at the second decade of life. Many patients develop symptoms after a thrombotic event ipsilateral to the iliac obstruction. It is not clear why no thrombotic obstruction leads to symptoms at some point in somebody's life without taking a thrombosis. But I've seen enough patients like that, the minority, the majority, who have symptoms with non-thrombotic obstruction. Many patients develop signs and symptoms due to iliac vein obstruction alone or in combination with other pathologies and factors. Further studies are needed to understand the importance of iliac vein obstruction and how intervention impacts clinical outcomes. The key point is not coming to chronic venous obstruction. The hemodynamic significance is not always obvious because clearly most people develop symptoms when sitting on a chair, studying, almost when they walk. Unfortunately, all the tests we do, IVUS, venography, CAT scan, and MRI, are done with a patient in supine position. And we look mostly for morphology, but not dynamic changes. And that's why the evaluation is inadequate and controversial. Until now, there are not robust diagnostic criteria for defining what we call hemodynamically significant obstruction. The disease is underdiagnosed and undertreated. And in many places, ironically, it is overdiagnosed and overtreated. Recent validation for some of the criteria using IVUS and venography exists through the video trial. Training for ultrasound evaluation is lacking, and formal training needs to be established. More work is needed to determine clinical outcomes in relation to treating various types of venous obstruction. This is very important because very little work has been done on the last point, and this is what we need to establish this as proper treatment for most of our patients. And finally, guidelines for follow-up after endovenous procedures have not been established. Follow-up consists of clinical exam and objective imaging. Most practitioners parallel the arterial serial follow-up. Ongoing and future studies will demonstrate what is needed for endovenous procedures. Thank you very much.
Great presentation. Thank you.
Amun?
Thank you, Nikos. That was great. Thank you very much. As always, you enrich us with your imaging science. Can I be a devil's advocate here, Nikos, and start the questions before we take any from participants by speaking about Mills-Turner as a manufactured syndrome? I find Mills-Turner, exactly for the reasons you mentioned, not be a real clinical entity, to be honest, because most of the imaging is done in the supine position, as you explained. So in any of us in the supine position, we have a Mills-Turner. Second, all the interventions we've been doing for years now, including stenting, are short-lived. So most of these patients in a couple of years, 3 years, they'll have an occlusion of the stent and they're exactly where they were. And third, and most importantly, the symptoms do not seem to be related to either degree of obstruction or stenosis or to the therapy we give them. Any comments?
I would comment.
Yeah, go ahead, Patricia, I'll talk after.
Yeah, hi. You know, I appreciate, I like learning from you, Nikos, but I'm going to address this last question or comment. There are many people that I've treated over the last 27 years who have stents that are patent for decades. And I think the problem is we have a lot of people putting stents in iliac veins who don't have any training. So to Nikos' point, there has to be some developed training places where people get certified to know what they're doing. To just go in and put a stent that you can't take out in a young person and have it thrombose within a year is a travesty. And those people should be prohibited from doing another stent, but we don't have control of the situation. It's just completely out of control. But I will tell you that people who dedicate their practices to understanding venous disease like Nikos and I have done, and only treat people who are symptomatic and only treat them with a way that will last for as long as they live. And if you're not, and then you have a protocol to follow them. So if they have any difficulty, you fix it. Like that layering that Nikos is showing, you go in now with the Atlas balloons from an IJ approach, you do a high pressure balloon dilatation, you push that back, and they're good for another maybe years. You don't know, we don't still know how often that might have to happen. And we don't really know how many people get that problem. So we're tracking it now. But the biggest problem is that too many people who are unqualified are putting stents in and not putting them in for the right reason, not doing good inflow, outflow, the whole thing. I'm glad to be able to help participate in saying that. Go ahead.
Mo, in my opinion, I agree with you, because in our hospital, I've looked over the last 13 years that I've been here, what's going on. The vast majority of the lesions we treat are having acute thrombosis or they're post-thrombotic. We do treat some people with compression, but that's the exception, not the rule. And I find hard to believe why in many centers around the world, the non-thrombotic lesions that they treat are more prevalent than the post-thrombotic ones. And to me, it doesn't make any sense. And then I talk to many other ethical guys like you around the US and other countries, and the vast majority of the people who use proper criteria, the post-thrombotic lesions that they treat or acute thrombotic lesions, not the non-thrombotic ones. As I said in my talk, often, for the reasons that you mentioned, this is an innocent bystander. Some of these people, for reasons we don't understand, do develop true symptoms and need to be treated. But in my opinion, this is the minority, not the majority.
Thank you very much, Nikos. We'll take some questions from the attendees, actually. I will start by a question from Ahmed Gawish, our good friend and excellent contributor to our Venus Forum as well. Ahmed is asking you, Nikos, about thrombus layering. It's quite common finding following iliac vein stenting. How can we avoid it? And does it have any clinical significance?
What we've done recently, Mamoun, we give an aggressive anticoagulation. Particularly all the post-thrombotic, we do. If there's an acute event, we do from 1 to 3 months low molecular weight heparin. Unfortunately, we found that the DOACs, they have a high failure rate in the immediate post-stenting period in post-thrombotic limbs. And that's why we have switched now for about 7 to 8 years to low molecular heparin. And then at 1 or 3 months later, we switch it to DOAC. I think one of the reasons is not giving proper anticoagulation or the patient not being compliant. And now, if you see some small layering, that's not important, but often if you follow up the patients, this converts to a bigger problem and needs to be addressed like Dr. Thor Patricia said earlier. You need to go with a big balloon and really beat the stent as much as you can to prolong its life, basically, in its patency.
Excellent. Any of the panelists have any comments before we take the next question?
Yeah, Nikos, I have a question. First, I enjoy your lecture. It's excellent, really. How do you explain the stent fracture, even though the retroperitoneal space is a fixed space, relatively compared with like SFA area? So why think stent fracture happened in this area?
Yeah, the most common areas for fracture are really the area of the guinea ligament and the area of the fifth lumbar vertebra, right? The vast majority of the tests in our study from Denmark saw these locations. It can happen in other areas because of stent overlapping and bad angle over time, and particularly if you use two different stent designs. But to our surprise, what we found, it doesn't matter where the stent fracture occurs. In the majority of the occasions, it did not lead to thrombosis. Right? Where on the arterial side, stent thrombosis leads to stenosis or thrombosis.
We do have a question from Mark Whiteley, and you know, Mark is well known to everybody. Maybe Khaled, you can bring Dr. Whiteley on to ask the question directly. So to use the time before Mark comes on, he's asking you, Nikos, do you find plethysmography helpful in non-invasive, as a non-invasive investigation of obstruction? Does it help the duplex?
Well, listen, all the techniques you use are operator dependent, okay? The ultrasound is the most operator dependent. In the good hands, is an excellent tool, basically, for everything in the abdomen. But the thing is, what do you do after? If your experience is low, you can, and the clinical suspicion is very high, you do IVUS venography. If you seek for differential diagnosis, in my opinion, you do a CTV, because the CTV is less operator and patient dependent, because the MRI is extremely patient and operator dependent. Okay, so I would do a CTV. But as I said, if you're in a good center of experience, if the symptoms are there, then after ultrasound, you can do IVUS venography with test to treat and skip the CAT scanning. And we use CAT scanning only if there is we want a better differential diagnosis to look for other causes, basically. But I would trust ultrasound in good hands. And basically, if the people who do the exam, they see that the exam is technically difficult or inadequate, then of course you go to some other testing.
So just to jump in here, we have about 200 participants on the Zoom only, in addition to perhaps a similar number. We don't have the final number from the Facebook. I want to make sure that everybody knows that this seminar really is sponsored by the SIGVARIS group, Elastic Stocking, and they are helping really in the whole process of education. We really want to thank them all. So everybody knows this is a combined effort with the industry from SIGVARIS group. Thank you very much, the SIGVARIS group. We are bringing Dr. Whitley to the panel. Is he there? Well, it seems we have difficulty in doing that. So thank you, Nikos. I know we can go ahead for many hours discussing this subject, which is very important.
Before we go, just let me take the opportunity to talk about the SIGVARIS.
Yeah.
When we treat people with chronic venous obstruction, right, the majority, in the 50% of them, were unable to cure their edema. Their edema may go away or being reduced, but in 50% of the patients, the edema does not go away. And the explanation is the following. Chronic venous obstruction leads to the impaired lymphatic function, so this is called phlebolipedema. It can happen from reflux or obstruction or both. And the impaired lymphatics or phlebolipedema is a non-reversible situation, as been taught by Dr. Peter Mortimer from London. And therefore, these people should continue having, you know, compression support, right, to alleviate their symptoms from the edema after you put a stent or any other treatment. And as I said, in multiple papers, it's very obvious that the edema does not go away in 30 to 50% of the patients, even if you do everything correctly. Thank you.
Nikos, don't you think there, in some of my patients, there is also deep valve reflux that comes from years and years of obstruction, and that won't correct itself with a stent.
Correct.
Yeah.
That's another contribution, correct.
So I have some difficulty doing the Zoom, but we'll work on it in a second. I will introduce our second speaker here. Before I do that, again, we have about 200 people on the Zoom, and I want to bring up, because this is the first time we do it under the Middle East Venous Forum, and on behalf of the board, we welcome all of you and thank again SIGVARIS for this opportunity to do the webinar, and the panelists who are the board of the Middle East Venous Forum, and it includes the professors Mamoun Bashir from Jordan, Samir Kosayer from Saudi Arabia, Dr. Francisco Sereno from United Arab Emirates, Dr. Martin Marish from Bahrain, and Dr. Nikos Lapravoulos from New York, in addition to Dr. Kevin Bauer from Ohio. So our next speaker will be Dr. Patricia Thorpe, who is very well known in the venous area. Dr. Thorpe been through many organizations, a great teacher, a great lecturer. She's a clinical associate professor of radiology in University of Arizona Medical Center, and she works also St. Luke's Medical Center. She's been an instrumental person in the understanding of venous disease. She was before in Wright State, then in University of Iowa, and she has multiple actually publications and lectures on the field. Dr. Thorpe will be talking to us about significant factors to successful venous interventions. Dr. Thorpe.
Thank you. Thank you very much for the invitation. And do I share screen now or what?
Yes, ma'am. Go ahead, share screen.
And then. Okay. Well, thank you for asking me to speak. It's just a huge topic, and like Nikos said, we could speak hours. But I wanted to start with principles of iliac stenting that I will illustrate with several cases, because I'm speaking to people who are just starting to do venous stenting. It takes, every time I do a stent case, I actually learn something. They're all similar, but each person has a little bit different anatomy, and you have to address your repair or the intervention to treat the issue. So like Nikos mentioned, I don't treat people who are asymptomatic at all. This is not just a matter of they don't like the fact that their left ankle is swollen. That's not quite enough to have someone put a permanent stent in you. I have a very good protocol for evaluating people, and we'll start with this case here. How do we do this? The first case is a 31-year-old woman, and the reason I chose these cases is because I want to share with you why I think IVUS is so important if you're developing a practice where you care about iliac stenting and doing it well. She started on blood pressure pills in 2012. Then she did develop a DVT, and actually she presented with a pulmonary embolus from when she was hiking. They brought her into the emergency room, and someone put a filter into her because she had acute clot, which I'll show you a picture of. And it's not irrelevant that she had type A negative blood type. And I'll be noting that at the end, that I talk about the importance of blood types and anticoagulation. Now here's a picture of her thrombus. You can see a huge femoral thrombus going down into this area. So they put in a filter. And what happened was, subsequent to that, they brought her back to take the filter out. And when this was a cardiologist here in the state, and I like him, he's a nice guy, but when he did this case, he just did a venogram, saw that there was a stenosis here, and that's probably because there was thrombus there for more than a month, and it became narrowed. And he measured just with a venography 5.94 millimeters. And he did not use IVUS. This is the first case he did with stents. And he was like thinking like a cardiologist. He used small stents in the heart, so he couldn't imagine using big stents in the veins because he wasn't familiar with the anatomy, I guess. And here's his sheath. He had some problems putting a sheath in here in the vein. And what happened was he ended up putting small stents in the iliac veins, not knowing how compliant they are. Even with the narrowing there on the venography, he put in a 6mm stent in the left iliac. The patient was prone, so the left iliacs. So of course they embolized, and thank goodness there was a filter there, so they got stuck in the filter. He went up and tried to snare them, and I'm sure that this was a horrible day for him. And he ended up pulling one down. Here's an ultrasound image of a stent sitting there in the external iliac vein on the right. And he ended up trying to pull one down on one side, one down another side. They did a cut down. He called his buddies, and he was up in another town. And you can see the non-phasic flow in the common femoral, indicative of a fairly obstructive situation. And she's been on the table for, you know, a couple hours now. So in summary, you have a left thrombotic condition, but it's not totally occlusive, but almost. It's on its way to becoming occlusive, but they're heparinizing her. The right flow is okay. The popliteal entry sites bilaterally is how he came in. Cut down incision on the left, trying to get this stent out of the groin area. She didn't have any leg edema. I mean, this was like a patient who came in to have her filter taken out, and they decided to stent her left iliac. And at that time, her PTT was therapeutic and her INR was not. So what I want to ask you is, you being on this case, what would you do next? Are you getting the options? These are the options that I came up with, and are you going to be able to vote on them? I think. Would you just put this lady on Lovenox? She's quite young. She doesn't have any other comorbidities. Would you start her on Coumadin? Would you, this was 2012, so I don't think we were using too much DOAX. Discharge her and repeat a duplex in a week and see how she was doing. Would you percutaneously try to retrieve some fragments since you already have a cut down? Would you actually do a surgical removal, or would you stent both of the femoral segments from below at that point? I can't tell if anybody's voting, are they? Can you hear me?
We can hear you really. I think Khalid is trying to do it in polling now. Khalid, go ahead. But there is no A, B, C, D, the problem. So you can count and get the number, guys. Yeah.
Shall we wait a little bit or a minute?
Let me text him, yeah.
Well, this is a controversial case because there are other, I've talked to many people, and some would just send her home. Some would do the surgery right then. And
yeah.
Some would,
so go ahead, we'll see if we can get the answer later. Go ahead, because we are trying to get the polling. Yes.
Okay. Okay, so, well, this is the patient. We did what we could to remove from the, she was transferred to Arizona Heart Hospital that day. And Dr. Ramai, the vascular surgeon, went in and found the stents here in the iliac region. And we were able to remove what we could. Oops. And here's one of the stents coming out. You can see they're small nitinol stents. And there's one 6x40 that was pretty mangled with thrombus. Here's another one 6mm by 80. So of course, 6mm is way too small for an iliac vein. The smallest we ever use is 12. Most women take 12 to 14 to 16, and most men 16, 18. And we judge the stent size that we're going to put in by IVUS. Now, grant you, I didn't have IVUS in the very beginning, and I put in a lot of stents, but in the beginning of wall stenting in the 90s, there were only 12mm stents. So we did treat a lot of people with 12mm overlapping stents for the length, and I can tell you that a very high number of those patients are patent still, but they were put on anticoagulation because they were done for post-thrombotic problems for the most part. So many of them are on lifelong anticoagulation. And when the patient says, when can I stop this Coumadin? I said, well, if you stop it and it happens again and you rethrombose, I'll help you again. And don't worry, but nobody ever wants to do it again. So most people are glad to stay on anticoagulation, especially now with home monitors. So those are the right inflow vessels you can see on both legs. The femoral veins were okay. You can see the stents here at the top. They come down usually to the inner trochanters where we stent to, because she had a lot of problem here in her groin. You can see this is the obstruction here on the right groin. And here's the left groin was narrowed with thrombus still inside. So what happened was she did in fact go home after we took the stents out. She healed her wounds. She came back in about 2 weeks and we went popliteal again. And we did in fact end up giving her kissing stents to treat both sides. The right side was obviously much worse. I don't think it's a very good idea to stent just this area, because there will be collaterals that come up from the upper thigh into the internal iliac and bypass this stent, and then you will have a thrombose stent, and you'll have flow going through the path of least resistance up through the common iliac, through the internal iliac. So it's never a good idea to put a solitary stent in this area or this area. It has to be extended, in my book, up into the iliac, the IVC, so that you have good outflow and good inflow. And this follows the principle. Now, she was done in 2012. I talked to her probably every 6 months. We do an ultrasound every year. She's doing really well. I do believe that she has gone off Coumadin now and is on Eliquis. Here's another patient who is interesting, and for a different reason, they didn't have IVUS. And I think that first case is a testimony to how important IVUS is and how it can save your career. If you don't want to stent something incorrectly, you don't want to put too big of a stent in, too small of a stent, and you want to stent just to the right locations. So this patient is interesting because she came from Northern California, and she also had birth control pills, developed a left iliac DVT in 2007, then a PE. But what she developed a lot of symptoms of left leg claudication and heaviness and edema. And she really her quality of life was pretty bad. She was actually a cook for a commune up in Northern California. I mean, it sounds a little odd, but she was a very nice person, to work very hard, and had some nieces and nephews who were always with her, and she played her cello. And this is the thing that was really sad. She couldn't even dance at her own wedding because of this leg. So she was evaluated before she came to me in Reading, then UCSF in San Francisco. Then she was referred to Stanford. And Dr. Khan referred her to me when I spoke at his meeting. And I said to them, has she ever had IVUS? And everybody said no. I said, well, that's probably the problem. We just don't really understand what's going on the inside. Now, this is the thing, she was large, and I've treated large women and men since then, and she was a big lady, but she was proportionally large. Her left thigh was 1 centimeter larger. That's not too bad. Her blood type was O negative. She was factor V positive and factor II negative. So when you see the images, you can understand why no one really wanted to do anything, because the measurements were pretty impressive. This is the first venogram from Redding, California. And this is a venogram that shows they did the measurement, and it was 30.3 millimeters, right at the point of compression. And you can see how the vein is, in fact, indented at this point, and there's some pre-stenotic dilatation, which is classic. The other side is a little bit narrowed, but her leg was pretty symptomatic. You can see the blotching consistent with the condition of livedo reticularis associated with her venous claudication and high pressures. More than that, she was quite symptomatic with not being able to do a full day of activity in a young woman. So ultrasound is where I started with my tech, It's really important to get a dedicated venous tech in your team, on your team, if you want to do this kind of work. Patty has worked with Nikos to learn more from him, but she's just one of the best I've ever worked with. So you can see the images like Nikos was showing us with the artery of narrowing the vein. And what?
They won't.
I didn't hear you.
No, we are muting other people. Go ahead.
Okay, sorry. So you can see that she has discoloration on the left, some swelling, but not horrendous. It's just her lifestyle was so impaired. The left common iliac had a high velocity of almost 70, and then below that it was pretty non-phasic and much lower velocity. And this pattern is what you often see below a stenosis, a huge drop in velocity and the change in the waveform. So this is a bifurcation area, and here's the left with the artery sitting on top. So again, another image that's even more dramatic in terms of the compression. And I always make this point to patients who are asking about May Thurner. Iliac compression is something that is a part of a human anatomy. And we think about 1/3 of the population has a significant narrowing of thickening of the vein after being, pulsation for many years at L5. So we're all built the same way. 2/3 of the people don't usually have a symptomatic condition or a condition that you could even identify as abnormal if you did an autopsy. But the 1/3 of the population around the world that has this compression that's significant to change the vein then has the syndrome based on how many risk factors they have. The reason why people think May Thurner is more common in women is because the risk factor of hormonal changes and pregnancy pushes the scale towards women getting iliac DVT on the left because of those risk factors added to this mechanical risk factor. But now that men are taking a lot of testosterone injections, we're seeing a lot more DVT in men. So the risk factors of trauma, changing your hypercoagulability status, being at bed rest, immobilization, dehydration, all those risk factors compound a mechanical risk factor that you have developed over time. Then here's what hers looked like. Again, you see the ascending lumbar, the pre-stenotic dilatation, which is a classic for the fact that it's really tight here. But with these images, you see that you do not see how narrow that vein is. You're only seeing the transverse diameter. And that's why IVUS is so important, because you can see that it's wide, you can see that the contrast changes, you suspect that this is the narrowing, but it's the IVUS that shows you how narrow that vein really is from front to back. And this is the IVUS image. You can see right below the cava as it comes into the common iliac, how narrow this vein is. You do not see that with ultrasound and, with venography. And I'm sure that I missed a number of cases early in my career because I did not have IVUS. So I really think it's almost a medical legal issue as well as an informational issue to see what the AP diameter is. Here it measures 5.2 and the width is 23. Now what happens is these widths here, you can see where this was taken to right as it comes out of the cave. This is common iliac with the artery sitting on the vein, narrowing it. This is artifact right here from IVUS. And there's another image. There's a lot of inflammatory change here to associate with the narrowing. But what we see over and over again is this pattern with the artery and compression of the vein right there, and the AP diameter is narrow. So our job is to increase that diameter, and in doing so, we actually decrease the diameter of the pre-stenotic dilatation. Because what people seem to not realize in the beginning is that the abnormal part of the vein is not only where the artery is sitting there compressing it, but it's the abnormal part below that area that is very ballooned out and pre-stenotically dilated, the opposite of an artery that's post-stenotic dilatation. And then the vein gets quite a bit smaller in the external iliac vein. So what I do with IVUS to help you see how useful it can be is that you measure the diameter at these sites, the proximal, mid, distal CIV. These are 2 distal CIVs down to here, and then the EIV. And you can see the change from the IVC to where it's quite stenotic, and the diameter is 5.2. Now, there are people who have much tighter veins and much bigger changes in diameter. And this, remember how big this lady is. She's off the scale in terms of trying to understand the relationship between an average sized person. But what we have to do is help her. And you can see that 5.2 is way too small. It's 50% of this. And these are very wide, indicative of how compressed it is. So the idea is to correct this so that her leg gets better. And the way to correct it is to correct the common iliac stenosis right here. But these numbers confound everybody because we don't have stents that big. So what size stent would you put in this lady and not be afraid that it would migrate? And how do you figure that out? And this is what we've been studying, and what we studied a whole lot when we were doing the Vichy trial, is to come up with a way that we could give an index so you could figure out which stent would work. So if you use a 20 millimeter stent, you can go down and see where it would touch the wall. I'm gonna leave the IVC out. It would touch here, not here, here, not here, here. Let's assuming it would open to 20 millimeters. And here, here. So if you go all the way down to the proximal external iliac, you get 1, 2, 3, 4, 5, 6. 6 out of 12, which is only 50% of the wall would be touched by a 20 millimeter stent. 22, we have 22s and we have 24s in wall stent. Well, a 22 would be 60% too because of these numbers. You can measure more, but I take the first numbers and sometimes we get an in-between number. 24 millimeter stent will touch here, 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 here. So if we take 10 5 rows and we say 1, 2, 3, 4, 5, 6, 7, 8. 8 places on the wall, front and back, side and side, a 24 millimeter stent will touch. That's 8 out of 12. That's 66%. We have figured out with the engineers in the lab that if you go over 62% of touching with the stent, and it's long enough, length is your friend, to have it long enough so it touches the wall. Over 62% is the strength it takes to push that stent off will be so great it won't move. Anything below 62%, I don't ever do. So it has to be 62% or over. This 24 millimeter stent was 66, and so that was deployed. And believe it or not, of course, when you put a stent in where the narrow spot is, that opens a little bit and the part below comes in a little bit. It changes the flow pattern to be more of a laminar flow and it inlines. So here's the stent. I would say maybe it's over a little bit too far on that side, but it's all the way down to here. And then another stent down to here. So she had 2 stents put in. So that was a 24 millimeter stent that immediately helped her, and is a 2470. And she, the next day, had better flow in her left iliac. It was lower velocity. The stent could be seen with ultrasound, and the flow was patent. And that picture on the right was the next day of her leg. And she was extremely pleased with the results, and she has been. It was 2013 we did her. It's almost 6 years now. Every time I go to Reading, she comes to the meeting and shows me her new child. And immediately after we did this, the heaviness was gone. She can run with her kids, her nieces. She can stand longer. She doesn't have pain in her groin like she used to. She can play her cello. And her post-op pain resolved in about 3 days like it does on most people. So no one would help her because they had never looked with IVUS. And when you look with IVUS, it gives you the facts. It gives you information that you can work with. And if you have to say, okay, I do IVUS, I don't have a stent this big, you stop and you order the stent, and then you have a procedure on the day when you're ready for it with the right equipment. So the goal for iliac stenting is to reduce the symptoms that are changing people's quality of life or hurting their legs. You haven't seen patients, you know pictures of people whose legs have lots of skin changes. Both of these patients are mild, but their quality of life was considerably affected. It's the anterior-posterior compression that eludes people, and that pre-stenotic dilatation, which is abnormal. It's a sump for slow flow. And we've shown in an article that we just published this month in JVS that a number of the stenoses in that iliac segment are up near the confluence. So you have to be very sure about where your compression is coming in from the side so you don't stent too low. And if you have to stent too high, depending on the configuration, well, then we do kissing stents, and I'll show you that. Because the bifurcation configuration should be most commonly an inverted Y, but sometimes it's an H appearance, and that's when you need to reconstruct it. So the goal for the pressure here is, look at this. This is an upside down Y or inverted Y. That's pretty easy to put a stent like this. And this side will stay open, and you'll have a good result long term. I'm always thinking about what the patient is going to be like in 20 or 30 years when I might not be here for them. So then you see this patient. It's almost like an H. Here's the configuration, and sometimes the right comes up very straight, so it's almost an L, but this is like an H. And if you do one single stent here, you're definitely going to have your stent way over to this side. It's possibly going to, over time, endothelialize and obscure the right side. We don't want that to happen. Maybe 10 years from now, she needs a right heart cath. So in these cases, we do often kissing stents to have a good long-term result. I think we're studying the results of all these data now to see if we think that's a good idea, but it has to be done for the right reasons. And you see, here is a patient that we did this week. She came from Indiana, and she had a really bad leg, which I'll show you. And she was symptomatic too, and she's a nurse. And she was working in the COVID unit there in Indiana. So here you can see her configuration has an indentation here. And if you watch the contrast clear, you see it's much more narrow than you think, even top to bottom. And it was narrow AP2. And here's the pre-stenotic dilatation, where the contrast just sits there. And you see, you wait just a little bit longer, and it even gets more narrow there. So if you just did a simple venogram and didn't sit down and go through each image one by one, you might miss this and say, what's the big deal? Her flow is pretty good. But these are her legs. This is the leg before we had the stent procedure. She was on the table at that point. You can see she has changes of venous hypertension here on the left, a little bit on the right. And actually her right is larger, but she was complaining mostly of the pain in the left leg and the way her feet looked at the end of a shift. She took this picture at home last week. And she had cream on her legs, but you see how blue they are. And she's had multiple episodes of sclerotherapy and ablation over the course of the years. She's about late 40s right now, and she started doing that kind of thing in her 20s. These are her numbers: 7.1, 5.5, 18, 12, 9.7. These are the minimum diameters in her left iliac. And it goes quite wide too, right? So we chose stents that would not migrate and that would fit there, and we used a 2070 and a 1860 on that side, and we made a stent system for her. And I believe then in the end, to do the kissing stents properly with the right side, she has a 1690, the 20, this is the 2070, and then a 1860 here. So 20 was good for her. She did have a little back pain for 2 days, 3 days. She's going back to Indiana today. These are her legs yesterday. Left leg ankle is thin. They're not blue. Her feet are normal color. And her husband said he hadn't seen her feet look normal for many, many, many years. This is what her feet were like. And she'll take a week off and then go back to work. So you see,
Dr. Thorpe, you more 5 minutes maximum more. Yeah.
Thank you very much. 5 minutes more, or I'm over 5 minutes?
Yeah, it's almost over. Yeah, go ahead.
Yeah,
5
okay.
minutes.
So the stent, I'm almost done. So the stents are, it's really important to have good inflow and good outflow, because the stents fail, like was already mentioned. What good does it do to put stents in if they're not going to stay open? It's because the people putting them in might not have been trained in surgery. I was fortunate to have a surgery residency. There's a basic premise. You do not bypass anything without good inflow or good outflow. And if you ask a physician if he would do a runoff, if you do an aortic bypass with a patient who has no runoff, they would say absolutely not. So although the point of the profunda being open is important if they have a good collateral, it's most important to get good flow through the femoral vein in the thigh to give good inflow to those stents. They will not stay open without that. And we know that patients with a history of DVT and residual thrombus and blood type A, positive or negative, do best with Coumadin. They don't do well with DOACs, and they don't do well at all without any anticoagulation. The only people I've seen do well without anticoagulation are a few people with a single stent on the left iliac who have never thrombosed, because the flow is so great. It just is not, you can't stop it there, and it stays good forever. So Martin asked me to say one more thing about the blood type, since this COVID thing has come up, and we know we've studied blood types for years. But I just want you to see the reason why A blood group is the one having most of the problem with thrombosis in COVID-19 is because of all of the antibodies that are present and all of the antigens. These are all, it's very antigenic, and there are a lot of anti-B proteins in the antibodies in this. Can you see O? O does not have any antigens. That's why O is a universal donor, and the O population has had less problems with the morbidity of COVID. B is a secondary, and AB is the same, but A has been the worst, and they get such an inflammatory condition. So think of how the post-thrombotic syndrome has been reflected in the blood type. We've studied this since the early 90s. And if you look at the blood type distribution across the world, A and O are the most prevalent, but the most of the post-thrombotic syndrome comes in the A, not the O. So even though A and O are pretty much similar distribution, and A, B, and B are less, when you look at the USA and you see A and O distributions, the predominant number of people with post-thrombotic syndrome are all A and not O. And there's less O than you would expect and more A than you expect. So it can't be random, just can't possibly be random. And I just want to mention to you that men and women really don't have, sex has nothing to do with it. And the SEEP class is almost all clustered with the A positives. There are many more A positives than A negatives, so it's almost clustered with the A positive group. And the distribution of hypercoagulability issues like factor V, prothrombin G mutation, all of these are clustered with the A positive people, not the O. The O have very few except for antithrombin 3 deficiency. So you see, this is something that we've been talking about for years, and nobody would believe me. But I think now with COVID, having all these issues, it's time for everybody to understand this relationship to the genetic ABO blood type. Thank you very much.
Thank you very much, Dr. Thorpe. There are actually a lot of questions coming about the different subjects. I hope our panelists will help us streamline those. I will start with many questions about plethysmography for imaging in occlusive disease, and what is the best way to age the thrombus. And this is from Dr. Kabnik, actually came the best way to age the thrombus. So before we go to the third lecture, I like the panelists and the two lecturers and the lecturer, all of them answer those questions while we are streamlining the other questions. Nikos, you can start. Unmute yourself, Nikos, you're muted.
MRI has been shown to do some aging with deep blood.
Regarding the plethysmography, I think although it's not used routinely, as most people don't have it, it is helpful when the obstruction is actually shown and is present. If the plethysmography shows no obstruction, actually obstruction cannot be excluded in many patients. So we can take plethysmography for its positive value, but not for its negative. Okay, and that was
so the aging factor. The aging factor was talking about MRV also, yes.
Yeah. For the age of the thrombus, now we're looking at the scenario now here. If you have a patient, you cannot decide if it's acute or chronic obstruction or combination of the two. First, you go by the symptoms of the patient, the presentation. If this doesn't make the cut, I think you should, the easiest thing to do with the imaging, in good ultrasound hands, you should be able to see vein dilatation or to see the fresh component of the thrombus. If you're not quite sure in that scenario, then the next step is to do a D-dimer. It's easy and fast, right? If your ultrasound is negative and D-dimer is negative, there is no acute stuff going on. One other thing you could potentially use is look for a special MR or even a regular MR to see if gadolinium leaks the venous wall, then you know for sure this is a fresh thrombus. Okay? But in the majority of the people, actually we have an ongoing study, in 90% of the occasions, with the clinical symptoms and the regular ultrasound, you can tell if the thrombus is acute or not. Okay? I'm not going to give another lecture now, but I hope you get the point.
Dr. Thorpe, you were saying something about MRI also?
Well, Steve Black had done some work trying to age thrombus. For me, I mean, it's not too much of a practical issue. You get mostly the history if people have had repeated episodes or this is the first episode. And if the question is whether or not you can treat them with TPA, if it's only acute, I've treated people with more of a chronic history because most people present with the combination of older clot and acute clot on top of that clot. It's layered and it's not simple, it's multiple variables. And over the years, we've treated people with, we don't know how old it is, but when it dissolves, you know, it's less, it's acute.
Okay. Any other questions, panelists, before we go to?
Yeah, I think there's a lot of questions coming about anticoagulation protocol after stent placement. It's a very controversial issue. I'd like to hear opinion from Patricia and other panelists. So what the anticoagulation protocol after stent placement?
It's I classify patients as to their blood type because I know that people with O positive blood have less tendency to thrombose anyway. And those data were from the 60s when they started studying people with birth control hormone changes affect people with blood type A, not blood B, O very much. So we know that for a fact. So any foreign body and disruption of the endothelium, I protect them with Coumadin. If they've had DVT, I transfer them to Coumadin and give them a Lovenox bridge before the procedure, and then we start the Coumadin back after the procedure. If they're on Coumadin, of course, they keep them on Coumadin. But if they're non-thrombotic and they get new stents, we do the Lovenox for 2 weeks and then convert them to Eliquis. And we watch them at 3 months and 6 months. I've had a number of people stop Coumadin because they didn't want to do it anymore, go on Eliquis, and they ended up getting that layering within their stents. We have no way to profile those people and see who's going to be a bad player and who's going to be a good player. So it's a lot of data, it needs to be collected, but I always put them on either Eliquis or Coumadin. And you want to know for how long? 6 months to a year. Then we check them, and if they're doing well, I can take someone off Eliquis if they insist, but then we get an annual ultrasound. And the minute they start having swelling or heaviness in their leg, they come in and we evaluate them. And once they fail, either Eliquis or not being on an anticoagulant, then we put them on Coumadin.
Patricia, do you see any role for antiplatelets for these patients?
Well, I do have people on Plavix for a month, Martin. But you know, Dr. Rena back east, Renu Vermani, she says that no one understands the role of platelets in venous thrombus. It's not like arterial thrombus. So there's no data about that. We're only copying the cardiologists, and we're hoping that it inhibits neointima in the stents. I don't know if Nikos has seen anything in acute cases, but we do Plavix for a month.
So for this question, Martin, yes. soon the REVA trial from Niels Kucher will start or has already started, which will check on rivaroxaban plus aspirin or not, if there's any value of putting any antiplatelet to rivaroxaban. So I think this study will soon give us some information about adding antiplatelet to it. I do have a comment to Nikos.
Can you introduce yourself first to everybody?
Oh, I'm sorry.
Hi, Michael.
Hey, Michael, I know, but I want him for everybody else. Go ahead, Michael.
Yeah, so hello. I'm Michael Lichtenberg from Germany. Thank you for inviting me here. Good to see you all. Yeah?
Thank you.
Nikos, you mentioned that you stopped at least DOACs, or you don't have very good experience with DOACs. Does it count for every DOAC? Because Patricia seems to have very good experience with apixaban.
Oh, Mike, that's a very good question. I said that only in relation to stent and only the first month, because our center and 3 other centers in the United States that at 10% of thrombosis being fully covered by DOACs. It's more common on, it was more common on Xalerto than rivaroxaban with a ratio of 1 to 2. Mm-hmm. But both of them, for the first month, they were not giving adequate coverage of massively ephemeral thrombosis. So as of many years ago, like 2014, I believe, we convert to 1 month of Lovenox and then put them, DOACs are really good drugs and we believe in them, but we use them at a month later.
Oh, I see, okay.
And now using Lovenox for the first month, we didn't have any thrombosis. Now, the other strategy we use is the following. Any patient with at least 2 episodes of DVT, proximal DVT, goes on live, right? Any people have a double hypercoagulability, 2 factors together, any factors, they go for life. And any patient with any major factor, such as antithrombin 3, for example, they go for life, okay? And then we have 2 scenarios, the non-thrombotic and the post-thrombotic. Post-thrombotic are very aggressive, treat for 6 months, and depending on the scenario we discuss, we go stop there or go for life. The non-thrombotic ones do peri-procedural and may continue treating ourselves, basically giving some type of antiplatelet. The evidence exists only for aspirin from the 2 randomized trials, and their meta-analysis reduced recurrent thrombosis at about 33%, at 1/3, but nothing more.
Thank you.
Okay, we have two questions from actually the panel, from the attendants. Unfortunately, I don't see the names, I see the numbers. One of them, go ahead, number 178, I don't see the names. $177 also, who raised his hand. So it's not showing the names, unfortunately. Okay, so to keep the time really, we will go with the next, the third lecture by Martin Marish. Again, I would like to thank, before we go to Martin, I need to thank SIGVARIS, the speakers, the panelists, and all the participating partners actually, whether it is on the Zoom or on the Face live streaming. We reached the highest number, about 206 on the Zoom, but everybody's still there, most of them are still there. And we promise to improve it as we go. So Martin Marish is a consultant vascular surgeon from Bahrain, and he is another board member of the Middle East Venous Forum. He will talk about venous stenting in the young patient. Then after that, we will have a session for discussion about 10-15 minutes before we end the program. Thank you, Martin.
Thank you very much, Munir. Good evening or morning, depends on where you are watching this, this first webinar organized by our Middle East Venous Forum. I have chosen the topic of stenting for young patients because I'm sure I'm not the only one who is pretty much concerned while putting the stent for the patients in their 20s or 30s. And we all know that, you know, the life expectancy of these patients might be like 50, 60 years. And 50, 60 years from now on might make a big changes, and we don't really know what's gonna happen with the stents after 50 years. Let me start my presentation. I promise I will be short and brief, and I will just highlight the points for discussions. This was a recent case of young lady, Fatma, who suffered deep venous thrombosis of her left lower limb while she was pregnant last year. She was treated conservatively on anticoagulation only, and after delivery, within like a couple of months, she developed severe venous claudications and persistent edema and pain and very typical post-thrombotic syndrome. And she's very young an active lady, so she was asking for treatment. This was her initial venogram. This is in prone position. It's a left side popliteal access, and as you can see, a lot of collaterals and a disease in the iliofemoral segment. So we did the venoplasty with high pressure balloons, and I was commenting on this final venogram that it's looking very well. And she was very concerned about stenting itself. And she asked me not to put the stent and try to go without stenting. So I ceased the procedure after this initial 20 minutes, and she was doing very well. Fatma was very happy and she improved a lot, and the pain was gone and the edema was gone as well. I kept her on Clexane and I was about to put her on warfarin. But unfortunately, within a week, all symptoms got back. And because she experienced this 1 week without symptoms, she was asking for intervention. And I explained her that this is what happens in the venous bed, and we can hardly get out without stenting. This is the groin ultrasound of her. You know, this is at the level of the inguinal ligament, where you can see almost complete obstruction of the flow. There was a good inflow from the deep femoral vein, which is the main inflow vein. And this is the second procedure. This is a supine position, but again, the transpopliteal access with a long sheet. I used the IVUS to precisely size and position the stent itself. This is the distal stent. You can see the distal end at the level of the ligament, just above the deep femoral vein. And this is the proximal stent over here, reaching the IVC. And after ballooning, this is the final venogram without any collaterals. And this is the ultrasound, which is mandatory after each venous procedure. because you have to be sure that there is a good inflow, which is the basic of the successful recanalization. And Fatma is doing very well. She has improved, and she was suffering from some back pain for 2-3 weeks. We managed with painkillers. She's on warfarin now, and she got back to her regular daily activities. The problem about venous stenting in young patients is with the heterogeneity of the patients groups, because we are treating very different types of patients. The first group are the patients with non-thrombotic iliac compression syndromes, like the May-Turner phenomenon, which is associated with increased venous pressure and the venous hypertension caused by the obstruction itself. Then there is a group of patients suffering from compression syndromes, but complicated with the acute DVT, and the management of these patients is very different. And the third group of patients are the patients who suffered from DVT in past, and they were treated conservatively, and unfortunately they developed the post-thrombotic syndrome. And as you can see, the prognosis of each of these groups are completely different. The pelvic, the venous compression syndrome is more common in females, and there are like 2 common presentations. The classic one is the young female in her 20s who is coming with acute DVT, with or without any other risk factors for the DVT. And the other group are the patients with a compression and suffering from chronic venous insufficiency or different and various symptoms from the varicose veins to venous ulcerations. The venous thrombosis itself is very common, and it's on rise among the population. 1/4 of these DVTs are located in a proximal iliofemoral segment, and these are the patients who develop post-thrombotic syndrome. And that's why there is such a big difference in the management of the distal and the proximal disease because of the post-thrombotic syndrome. So what is the goals of the treatment? We are trying to relieve the symptoms, which is pain and swelling. We prevent pulmonary embolism and recurrent thrombosis. We prevent post-thrombotic syndrome by restoring the vessel patency. The best scenario is preserving the function of the valves, and we do it by correcting the underlying structural causes. So it's the venous stenting is broadly accepted nowadays and recommended by the major societies. So let us just go through what we know about the stenting. We know that the better we clear the thrombus and the blood clot within the iliac veins, the better is the result. And if we cease the lysis without cleaning the clot properly, and we leave like residual clot inside the vein, then we risk the good long-term patency. And we also know, as we learned with Fatma, that the ballooning alone doesn't work in the venous system. The rethrombosis, despite the anticoagulation, is significantly more frequent in the group with untreated lesions. We know this, and even the long-term results are much better in the stented group of the patients. And we know that this was one of the drawbacks of ATTRACT trial. It's not only the stenting; it's also correct stenting, which is very important. So the sizing of the stent is the key factor, and many operators are trying to undersize the stents in a false fear of rupturing the vein, which is not the best practice. And Patricia already targeted the importance of the IVUS use in these patients. The most common complication is instant thrombosis. This is what we fear the most, but it's not that common actually. It's the early is less than 3%, the late rethrombosis is at the level of the 5%. So what we know from the big cohort studies is that the restenosis occur only in 5% of the limbs. And the chief risk factor is the blood clot itself. It's thrombotic disease. It's very unlike the arterial disease when the problem is the stent itself. Here it looks like the problem is the thrombus and the blood clot. You can see the Raju in his like more than 1,000 limbs study. He re-intervened in 13% of the limbs, which is quite a high number. And it's very obvious that the lifelong follow-up is mandatory for this patient. What is important here is to see that less than 1/3 of these patients in need for intervention were discovered on imaging. And almost 70% of them, they needed their intervention because of the recurrence of their symptoms. Many of our patients are the fertile females, so it's very important to know how the stents work in pregnancy. Oliver studied 6 ladies, and in general, we know that during the pregnancy, all these females are getting worse because of the compression by the enlarged womb, and majority of them you can identify the compression of the stents. But if they are managed properly, which is usually anticoagulation with low molecular weight heparins, they can go through the pregnancy without occurrence of the thrombosis, and after the delivery they are doing pretty well. The current recommendations for these ladies is to wait for 1 year after stenting with next pregnancies. It's good to do the ultrasound scan prior pregnancy and check the stent patency, and then to repeat the ultrasound at 3, 6, and 8 months of pregnancy, and then 1 month after delivery. And of course, the low molecular weight heparins are recommended from the 3rd month of the pregnancy till the 1 month after the delivery itself. We've already discussed the issue about the configuration of the stents, and there was in our chat there were like remarks about how far we're supposed to go inside the IVC, but the contralateral limb thrombosis is actually very rare, and it's because of the flow through the pores of the pseudointima, which is created over the stent itself, can maintain the flow for a long period of time. And it's actually much more important to tackle the exact May-Turner point. So the risk of contralateral limb thrombosis is less than the risk of thrombosis of ipsilateral side if you miss the May-Turner point and you leave the compression there, because we know at the very end of these venous stents, the radial force is the lowest, so it's very easy to get compressed. So to minimize the need for the reintervention, it's the most important is to treat in the right way, appropriately. So it's not about either stenting or not, but if you go for the stenting, it should be a proper stent. Patricia and Nikos already discussed the importance and mandatory role of IVUS. The lifelong follow-up and a good imaging surveillance is a key factor to tackle the patients in need of reinterventions. These reinterventions should be indicated according to the symptoms, not only the imaging itself. It's very important to clear as much thrombus as possible, not to leave any blood clot there, because the thrombus itself is a key factor in rethrombosis, and ensure that the stent has appropriate proximal and distal lenting zones, so good inflow and good runoff, as we already mentioned. The extension of the stent proximal or distally may be necessary to cover previously missed skip lesions. This is for the reinterventions itself. Anyhow, there are a lot of controversies we can discuss till morning, perhaps. It's not very clear still, like if there are any patients we can get out of treatment without placing the stent. We don't really know, and Nikos tackled this very nicely. We don't know what are the objective criteria for stenting for the venous patient suffering from venous hypertension because of due to obstruction proximally. It's not very clear, as we said, what kind of anticoagulation and antiplatelet and for how long we're supposed to use in different kind of groups of these patients. As we mentioned, these patients are very heterogeneous. We don't also, it's not very clear what is the ideal follow-up scheme as well. And I think we have to discuss also the proper management of the deep venous thrombosis in pregnancies, like who is the candidate for more aggressive treatment and how to perform this more aggressive treatment. So these are the points for discussion. I wish you a happy quarantine, and I hope after this Corona times we'll get together in person, or perhaps in Dubai.
So thank you very much, Martin. And yes, the other thing, we are planning the meeting in Dubai, but we don't know when. So far, it might be September. I put actually Dr. Kapnick, Lowell Kapnick on the panelist. He has a few questions. Lowell, go ahead.
Lowell, unmute.
Yeah. Hi. So for me, yesterday, we discussed some issues. And one of them really has to do with Nikos and his observations and looking at patients with compression. And when we look at patients with compression, the majority of the vascular labs do it in a supine position. If we look at this and do it in an upright position, would we obviate the number of patients with May-Thurner? That's number one. And the last question would be, also brought up was by Dr. Irwin, was the fact that no matter what we do, if we stent the May-Thurner lesion and go into the cava, it will touch the wall on the contralateral side, depending upon all sorts of factors for hydration, supine position, etc. So really, do we really need, for the rest of the panelists, worry so much about touching the contralateral side and the fact that you're jailing it? Thank you. Nikos, to you.
Yes. For the supine studying, Lowell is excellent comment, because for the last few years, we've been checking, and definitely a stenosis on supine position, it will get better or even disappear on studying. In support of this, there is a nice study with venography from Holland that they took asymptomatic patients that have stenosis on supine that disappear on the study position. But to us now, after 2 years of testing, it's very obvious non-thrombotic stenosis on supine position is almost non-significant, at least by a diameter, on study. However, few of these people, the stenosis, it might be becoming worse on study or does not change. So people having a fixed stenosis on studying or supine, that's probably the candidates to maybe look for treatment. But the majority, I agree, like it goes away if you stand up the patient. Regarding now the contralateral side, I think there are some technical issues here. The problem number one was the wall stent that it does not have good radial force and it extend the vena cava and stay open. Now with a nitinol stent, you don't need to go all the way there. Exception being is the small number of patients where the compression involves the distal part or part of the inferior vena cava going to the left, okay? But now, if you look technically, measure the distance from the left common iliac vein to the contralateral wall to the vena cava, the distance 2.5 to 3 centimeters, which means it's plenty of room to pin the stent on the iliac vein without having to reach the wall on the other side. Mm-hmm. I mean, and if you don't know how to do this, right,
Nikos,
The Nikos, easy nowadays. Or, if you have any doubt, you take your IVUS catheter from the contralateral side and you deploy your stent under direct IVUS vision.
So, Nikos, I would agree with you, except for the fact that we've all had done open vena cava repairs, etc. And we have seen different size diameters, even with respiration, as we're trying to take care of this. So I would submit that maybe it's not the full gelling, but I think you raise a good point, maybe with the algiloid stent, that the radial force there may collapse at that point, so then it is an obstructive area. So I don't know, but I just think that we make too much of it. I think the ipsilateral is more important.
Yes.
Thank you very much. So there's a question from the attendants, Francisco Sanfilippo. Go ahead. Francisco.
Well, if Juan Francisco is not there, then I will take the question for Pravin, which is from India, asking if he's not there. I will ask Martin, are you there? Okay, so Martin, he's asking if what is the ideal time for stenting after a Materna syndrome or after thrombolysis and treatment, if he's on the same setting of delayed?
It's a perfect question. There are like three groups. This was the question Dr. Kapnik already asked, like what is the cutoff time, the best, to intervene. And there is the acute phase, which is the golden rule of like 2 weeks. Some authors, they are talking about 1 month. And we all know that sometimes we intervene even after 6 weeks of thrombosis with thrombolysis and mechanical thrombectomy. And then there is a subacute phase when there is not really the best time to put the stent because the thrombus is difficult to get rid of, and it's still very active, and that's the timing when you can expect the majority of the complications. So it's better to wait for like 4 to 6 months and then to tackle the lesion as a chronic venous occlusion and then to do the stenting. But I guess there is a lot of questions like this. We prepared 3 polling stations because there is a lot of controversies we are unable actually to answer really because there are no guidelines. So instead of evidence-based, we can get the experience-based, and we can do the polling of the next 3 questions, which are actually linked to the configuration of the stents and the anticoagulation itself. And let us see what this kind of panel and the participants can get out of it. So the first question is, what is your preferred stenting configuration? This is what we've discussed right now. So the first is, I keep proximal portion of the stent outside the IVC. I place the stent into the IVC, leaving unobstructed portion of IVC. I place the stent safely into the IVC regardless the contralateral side. I use double barrel technique to protect the contralateral side like Patricia did. I use a John Turco Z-stent with a large distance between the struts into the IVC in combination usually with a wall stent. Or I use a new dedicated venous stent similar to the new sinus obliquus stent as Nikos mentioned. So let's see, we have 30 seconds to vote. You vote and then submit. And Khalid's supposed to give us the result of this polling. Okay, so the majority of this is beautiful because you can see how different opinions we all have. Of course, there are no guidelines. There is like 15, 31%, 15, 20%, and 17%. So, Michael, can you comment on this?
So this is very interesting to see, and I really stress what you said. A lot of opinions. Yeah. I personally choose the last one. I use new dedicated venous stent similar to the new sinus oblique stent. As with this stent, we have the real opportunity not to jail the contralateral side. But my second choice would have been number 2, I place the stent in the IVC, leaving unobstructed portion of the IVC. Probably that if you do not have dedicated stents like the sinus oblique stent. I'm definitely not in fear so much based on our experience about contralateral jailing and DVT.
I think we all do the same. We are trying to keep some portion of IVC free. So in case of any complication, you can basically treat the contralateral side as well with the thrombolysis, thrombectomy, and stenting itself. It's not very common. And if it happens, it's usually treatable nicely.
Martin, I think that the contralateral stenting issue is a technical issue, really. For all these years, I've been putting stents just a little bit into the IVC if you do a single left stent. And we've never had a right side go down, really have not. There's got to be a technical issue with people who have a lot of issues that way. Or we pay a lot of attention to the configuration of the bifurcation. And we don't want to leave a young person with a situation that might not be viable when they're 20 years down the road. So if that H configuration is there, I usually do double stents and change it into a V-shaped stent, and that's worked really well.
I've seen this. Shall we try another question for a polling? It might be also controversial. Khalid, can you display another polling question? So do you use temporary IVC filters? We didn't talk IVC filters yet. So doing pharmacomechanical thrombectomy treating acute iliofemoral DVT in young patients, do you use IVC filters or not? So the first is never, only in case of IVC involvement, only in case of floating thrombus on CT, in all cases, or I'm using a capturing device for selected cases. We have 30 seconds to submit it, and then we can discuss it. Perhaps some of the interventional radiologists can comment on this with us. Dr. Vasila, perhaps.
Hello, everybody. Could you hear me?
Yeah, go ahead.
I'm so sorry I'm not with the video because I didn't know before in an anticipated manner, so I'm not very presentable. But I am really glad to be among you, and I can see you all of you. And I can say that the Middle East Venous Forum is born a giant. This is the first webinar, and it's an excellent job. Congratulations, guys. We do in our team, maybe most of you know that I do a lot of catheter-directed thrombolysis. We don't do the mechanical pharmacothrombolysis. And in our team, because we do only the catheter-directed thrombolysis with RTPA, so in these cases, we don't use IVC filter in our cases. But as Lowell Kabnik said yesterday, there was a big discussion about the use of IVC filter in this context. And most of them with the mechanical thrombectomy, they use the IVC when the filter, when the IVC is involved, or the new one, the capturous one. I have a lot of comments and questions. I don't know if there is the appropriate time to get it now. Let me know, Munir, now, or I can postpone my questions.
Okay, Wasila, let's finish those and we'll
okay, perfect.
The field. Thank you, Wasila. Thank you.
Perfect.
Yeah, so we can see that we usually use the IVC filter only in case of floating thrombus, but it's also not really the guideline because I don't think so. We all do the CT venogram for all our cases. Yeah, so we don't really know if there is floating thrombus for all the cases or not. There is a lot of controversials here, and I'm sure we'll tackle them with next webinars as well. Can we get the last question?
Martin, on this really, the way I do it, I decide on the spot. When I do the venogram, if I find the proximal part is really loose, or I'll put the filter. Otherwise, I don't. And I do the filter from the popliteal vein. I don't go in the groin.
Because next question, Munir, is like, for how long do you keep this IVC filter? When do you remove it? Do it yourself? Because many of these patients get lost.
You're asking me? No, I remove it after a month or two. I tell them I'll remove it if there's no contraindication. Because if you leave them longer, they will not come back.
That's what I mean. Putting the IVC filter is a commitment. Then you have to fulfill it, because usually these patients, they are just getting lost afterwards.
Yeah, not the first month. Yeah.
The third point question is about medication, and we already discussed this. So let's see what the participants and the panel thinks about it. So what is your medication algorithm post-stenting due to non-thrombotic iliac vein lesion in young patients? Only antiplatelets therapy, 3 to 6 months, oral anticoagulation, and then platelets for life. Only 3 months of oral anticoagulation, then no medication at all. 6 months of anticoagulation and no medication afterwards. Or low molecular weight heparins for 6 weeks, then antiplatelets for some period of time, or some others. So let us vote for this. We already discussed about this, and there are no guidelines about it. I guess each of us are having his own algorithm, and it might be case by case as well, because it's important if the patient is cooperative or not. So the most common is 3 to 6 months of oral anticoagulation, and then we all believe in antiplatelets even for the venous disease. So it's very interesting to see these experience-based opinions. Thank you for polling.
So now, thank you very much. We will open it actually discussion. Before I do that, again, I would like to thank SIGVARIS for supporting and sponsoring this event. And thank you, Wasila, for saying Middle East Venous Forum born large. I cannot say giant though. And it's good because we have people like you participating. The other thing, part of the education, we have a huge education actually endeavors around vascular. One of them, I tried to see if Dr. Desai on the panel, he's not there. We have a web page in which we have multiple choice questions, case presentations with discussion. Please, anybody has any of those questions with discussion and why the answer, or case presentation and the discussion, please feel free to submit them, and we will provide the way to submit them, and it will be a huge education area for vascular, including venous. So the discussion is open. I have a few questions from Rashad, Bashar Rashad from Egypt, who is very active in the area of venous also, saying, is there a difference between the stents, the choice of the stents, in conformity, deformity, and deployment? So it's open to the panel, the question.
It's another great question. I have a lecture which takes another 25 minutes just about the differences
not today.
And I'm sure Michael can do the same, and Patricia as well. And I guess it depends also about the availability of the different type of stents as well. And the companies are working on it to getting it better and better.
So what do you prefer, Martin? Which stent, if you have all of them?
We are using the Nova stents and Medtronic stents, the Abre stents.
So Patricia, which one you use if you have all of them?
I can tell you that my decision is based on experience with failed stents. And when people came to me with failed stents, either thrombosed or crushed, and thrombosed because they were crushed under the iliac artery or at the inguinal ligament, I noticed that 85% of them were open cell nitinol stents. And I just do not like open cell nitinol stents for longevity. The wall stents have been good and stood up for almost 30 years now in our observations. We have many of them that we've, done secondary interventions on. And it's true that a wall stent will fray at the inguinal ligament if you do squats and lift weights, but not in everyone. So none of the stents are perfect, but the wall stents have been the best long-term. And I have a lot of faith in the Veneti stent because it was designed to be like a closed cell design, but it's not truly a closed cell design. So we have to see with long-term follow-up if it's going to last.
Mamoun, what do you saying? Unmute yourself, Mamoun, please. Until you are Mike Littenberg, until Mamoun there. Okay, go ahead, Mamoun, go ahead.
Yeah. So, well, the stent issue, I totally agree, and I've used recently all kinds of new dedicated venous stents, but I totally agree the Palmas stent is still the cheapest, the best, and the most tried, and I think I'm going back to using it. But I did have a comment regarding the cable filter issue post-thrombolysis. I've changed recently practice, to be honest, where I put a filter, a temporary filter, although I don't like filters, and I've published a paper a while ago about some rare complications of filters, including migration and penetration, etc. But for medical legal reasons, I'm recently putting filters in everybody I do thrombolysis on, cable thrombolysis, and I make sure that I remove these filters in about six weeks, because the one episode that you decide, this is not going to give a PE and it's not going to have a problem, will have a PE, and then you're in trouble. And it did happen to a colleague of mine, and it was a harsh lesson. So I don't know what the rest of the panel would think about that policy.
So Michael, you're next. What do you think is the best stent?
So I would like to answer this in a more general way. So I personally believe there is not a perfect venous stent for the whole system. You have different requirements. In the Mathurna area, you have different requirements below the ligament in terms of flexibility, radial force, crush resistance, and so on. So therefore, I think we need to talk about different stent designs, maybe which we combine. I personally combine an open cell 90-node stent proximal, and then a dedicated venous stent for below the ligament. And there are now, there's now even a woven 90-node venous stent on the market here in Europe and most part of the world, called the Blue Flow venous stent, which is a dedicated below the inguinal ligament common femoral vein stent. And so I combine these stent principles.
Because there are so many questions, we have another question about AV fistula. After stenting, again, quick poll. Mike, since you are there, would you put an AV fistula after stenting? Mike?
Me? Okay. So if I need an AV fistula after venous stent implantation, I probably did something wrong in the evaluation before. Because you have to find out before if there enough inflow, is there a problem with the inflow with the profunda or femoral vein. So the workup is, I think, not good if you need an AV fistula afterwards. So we always plan an AV fistula before, of course, so it's not a sudden decision. So you need to plan your case. So it really depends. And if it's really necessary because profunda is down or femoral vein inflow is bad, then we directly take the patient to the hybrid OR to perform both.
Okay. Wasila, you are there. What do you think, Wasila?
Let me just make
Go ahead, Martin, until Wasila is there.
Yeah. Comment to Mamoun, because I just loved his comment about the IEC filters, and I will just show you. I will just share my screen because it exactly happened to us as well recently. Can you see? Can you see my screen?
Yeah.
So after 400 cases without any pulmonary embolization, clinically significant, we had a massive embolization during the pharmacomechanical thrombectomy recently. and a young lady almost died on table, and we had to put her on ECMO, and cardiac surgeons around, and she arrested, and it was a hell. So what I don't like IVC filters because I told you it's a commitment, and majority of these patients they are just getting lost. So what I use the CaptureX. CaptureX is an amazing temporary filter. Which is very easy to use, and it's just it works amazingly. The problem is that it's expensive. So this is what I use for another patient. I just stolen the big size wall stand from cardiologist, and I put it transjugular because the wall stand is the only stand you can retrieve back. So I just put this semi open wall stand at the level. I will show it to you. Here you can see in the proximal part. This was a patient with a floating thrombus in the IVC, and he was very young as well. And I was not brave enough to treat him without protection. So I put this wall stand transjugulary from up, open it during the procedure. At the end of the procedure, I just sucked everything out from it, and then I retracted it after the procedure immediately. And this is how it looked like. You can still see this is after his aspiration. There is still some clot. So this gives you some feeling of security during these procedures as well.
So you are in a rich country to get rid of one full stent like that. They will shoot us here if I do it.
This one was expired, but I cannot say this.
Okay. Any other questions from the panel or from the group, please? Because we are almost closing now. A few more minutes. Well, again, thank you very much. Thank you very much, everybody. Thank you for the information, the participation. Wasila, you want to say something before I close?
Yes, please, Munir. Thank you very much for giving me such a great opportunity. I have some comments with Nikos, please. Hi, Nikos. Nikos, did you hear me?
Yeah, I'm hearing.
Okay, hi. Just maybe we have, because we have now 162 participants that are seeing us. And if you do agree, we have to revise the names of the DVT, acute and subacute, and mostly chronic DVT. We see a lot of reports of duplex reports with the misnomer, I can say, with the chronic DVT. What do you think? How we could replace this word appropriately? Because it's not anymore a deep venous thrombosis. How much you do agree for this, Nikos?
Yeah, in our hospital for many years now, change the term to chronic luminal changes or chronic post-thrombotic changes. There is no word chronic thrombosis.
Yes, right? but so, we see in so many reports the word chronic deep venous thrombosis. How we replace it? Chronic occlusion? Chronic occlusion?
You call the people and tell them to change it because chronic thrombosis physically and biochemically does not exist. We know very well if the fibrin does not lyse, it converts into collagen type 1 and collagen type 3. So there is no chronic thrombus. Okay.
There is no any more thrombus. This is the word, yeah.
But Nikos, explain to me why when we put in a TPA catheter in a patient with mixed chronic and acute, which is what we think, and you look with IVUS day 1, day 2, day 3, the whole thing changes. There's a thrombus that's resolving with TPA, and what's left must be the stuff that will not dissolve. So that may be more likely collagen in nature, but there is thrombus among all that synechia that resolves.
Yes, it may happen. If you take truly chronic cases, this doesn't occur because I have histological evidence for this now. But there are some people, a mixed picture, where there is channels within the old obstruction that may get thrombosis. And when you do the TPA, you may open these channels and you'll be able to negotiate a wire or anything else, through that. But in truly chronic situations, there is no, acute component by histology.
But it's a dynamic process. It's not dead. The clot comes and goes. So that's why I think the TPA has a role in some of these patients because they get much better after thrombolytic therapy. And then you can stent them more easily. It's not a static.
Patricia, I know of your experience, I respect it, but I disagree. Because by histology now, evidence by histology, there is no blood clot by histological terms.
It's only fibrin. All right.
Okay, any other comments before, because really we need to close as we promised for 2 hours. Any other comment? So again, thank you very much. And we appreciate your presence. We appreciate the time. We appreciate also SIGVARIS for sponsoring this program. We will come back next month with another webinar in venous disease. And we are open to any suggestions from all the friends. I know we have your emails now. We like to have this to be one of the most successful teaching conferences if possible. And I think by the interactions, the people who are participating, we have people actually from Italy, Europe, Germany, Russia, Brazil, South America, in addition to that, from India and the Middle East. So this is really an international meeting, and we are hoping to continue as far as we can. Thank you, everybody. And I think the board members, we send if we can stay 10 minutes after that. Thank you, everybody. Thank you. So Khalid will arrange the board members to stay 10 minutes, please. We'll see you next month. Thank you.
Bye. Goodbye. Thank you. Bye-bye. Bye-bye. Bye-bye.